In GPU you might have come across the pickle word. Pickle means pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. In this video, I'll be saying all that detail from Achit Pallor book. Pallor. Pallor is nothing but paleness of skin or mucous membrane. The sites where we look for pallor is lower palpebral conjunctiva, tongue, oral mucosa, palmar scissors. Palmar scissors will become lighter in case of severe anemia, and nail bed. Nail bed, you see. These are the sites where you look for pallor. See, lower palpebral conjunctiva like this from both the hands. Then pallor in the hands and soles. In soles we can see in children. Next, grading of pallor: mild, moderate, and severe anemia. We can see like mild pallor, moderate pallor, and severe pallor. Mild pallor, there won't be any clinical features detected, but in moderate pallor there will be clinical features visible, that is paleness will be visible. In severe pallor, palmar scissors will be there. Now this will disappear or become light color. And cervical venous hump, that is this suggests chronic compensation because of there will be lack of pallor. We've seen hemoglobin concentration will be there less. In order to compensate, there will be high you can see palpitations. No, that thing will be there. This was first seen by the Pontine. So Pontine murmur we can, when we keep the this bell side of the stethoscope near the vein near the carotid this triangle, you see the murmurs. You hear murmurs, that is called as Pontine murmurs, which was first observed by Pontine. Conditions where you see pallor. Conditions where you see pallor without anemia. This will be most favorite questions for Viva. That is hypopituitarism, hypothyroidism, hypogonadism, shock, and left heart failure. If shock is there, there won't be much blood to pump till the this area. So there will be paleness. And left heart failure. Heart can't pump. Left heart pumps blood to the whole systemic circulation. So there in that condition. And pituitarism, thyroidism, and then gonadism. Pituitarism, thyroidism, and gonadism, you see pallor without anemia. Anemia is nothing but decrease in the circulating blood count, that is RBC, or percentage of hemoglobin will be decreased, or hematocrit will be decreased, or PCV. Hematocrit is also known as PCV. This will be decreased below normal for gender, because for males will be having a limit more than the females. And age, infants will be different range, and pregnant ladies will be different, and other people, adults will be different. Normal adult hemoglobin will be for males you can remember as 14 to 16, and females 12 to 14. This will be the normal range of hemoglobin. And in there are different types of anemia, like iron deficiency anemia, where you see the spoon shaped nails, and pica, they feel like eating which are non-edible things. Dysphagia, difficulty in swallowing. This is one of the tried in Plummer-Wilson syndrome. Dysphagia, dysphagia will be there, iron deficiency anemia will be there, and esophageal webs will be there. So this will be iron deficiency anemia in Plummer-Wilson syndrome. You see Chylonychia, spoon shaped nails. In peripheral smear you see microcytic hypochromic RBCs. Normal size of the RBC should be the size of nucleus of small lymphocytes, but it will be smaller than the nucleus of small lymphocyte. And hypochromic is normally central 1/3 should be pallor, it will be more than 1/3 pallor. So this will be microcytic hypochromic anemia, iron deficiency anemia. Megaloblastic anemia, this will be macrocytic anemia. And you see glossitis. Then Romberg sign, you can see positive Romberg sign you might have performed, and deep tendon reflexes will be absent in this case. Peripheral smear shows macrocytic anemia, macrocytic RBCs. And hyperpigmented neutrophils. Neutrophils hypersegmented. Neutrophils are usually having 3 to 5 segments. It will be more segmented. And anemia of chronic disease, which is also macrocytic hypochromic anemia. Macrocytic hypochromic anemia you can remember as a TAILS. TAILS. T for thalassemia. A for anemia of chronic disease, I for iron deficiency anemia, L for lead poisoning, and S for sideroblastic anemia. This you can remember. And hemolytic anemia. In hemolytic anemia, you see both icterus is positive and pallor will be positive. Icterus, because of the destruction of RBC, there will be increased bilirubin level. So you can see in hemolytic anemia, you can see icterus also positive. There are so many Hemolytic anemias like sickle cell anemia, maybe parasitic infection like malaria, or hereditary spirositis, you see hemolysis, or G6PD deficiency or pyruvate kinase deficiency. All these conditions you see hemolysis. And aplastic anemia, there won't be any bone marrow left in this thing. So this is a congenital. Peripheral smear source, all cells will be decreased. That is pancytopenia. That is RBC, WBC, all the precursor cells won't be there. No, so all cells will be decreased. The WBC, the RBC, and platelets will be decreased. Specific signs, no organomegaly will be there. Usually organomegaly will be there, like hepatomegaly, splenomegaly. Spleen will be the graveyard of RBC. RBC will be destructing and going into the spleen. No, so there will be splenomegaly. Next. Next, coming to icterus. Icterus is nothing but yellowish discoloration of skin or mucous membrane and sclera, blood vessels, secondary to the increased bilirubin level. Because elastin has more affinity towards the bilirubin. The sites where you see for jaundice or icterus is sclera, yellow color. Sublingual mucosa, sub means below, lingual tongue, mucosa, oral cavity, palms and soles you see, skin you see. Normal bilirubin level is 0.3 to 1.2 milligrams per deciliter. It will be latent jaundice, means clinical features is not seen in this condition, that is 1.2 to 2.5. Even though bilirubin level is more than normal, you don't see any clinical features, that is known as latent jaundice. And more than 2.5 is not clinically appreciated. The jaundice is clinically appreciated. The pumpkin's face, chipmunk's face, knuckle pigmentation, you can see knuckle pigmentation. This is a type of anemia. This you see in a knuckle pigmentation you see in hemolytic anemia. You see knuckle pigmentation. There will be hyperpigmented knuckles. Then coming to, this is a yellowish icterus, that is a yellowish discoloration of the skin. Where you see discoloration of skin without jaundice, this hyperkeratonemia, that is increased vitamin A concentration. There you won't see sclera yellow color, remaining parts will be yellow color. Hypothyroidism, decreased metabolism of, in hypothyroidism vitamin A metabolism will be decreased, so vitamin A will be increased. Excessive exposure to phenols and nitric acid. Then quinine intake. Grades of jaundice, there will be mild and moderate, but with no specific grades, but still we classify mild and moderate. Only sclera becomes yellow, skin also becomes yellow, moderate. I think the different colors in jaundice will be lemon yellow color, dark yellow color, and then greenish yellow color. Lemon yellow color in hemolytic, obstructive, then obstructive, long standing. Bilirubin will convert into biliverdin. Hemolytic, obstructive, long standing. Bilirubin will be oxidized to biliverdin, so it becomes greenish yellow. These are the colors of jaundice. In jaundice, there are three types of jaundice: pre-hepatic, hepatic, and post-hepatic. In pre-hepatic, there are both hepatic conjugation takes place. So pre-hepatic, no conjugation will be, hemolysis will be there. So unconjugated bilirubin will be increased. In post-hepatic, conjugated bilirubin will be increased. In hepatic, both conjugated and unconjugated bilirubin will be increased. It shows biphasic. Then urine will be yellow color only in obstructive jaundice or post-hepatic jaundice. Stools will be urine will be yellow color in both hepatic and post-hepatic, whereas the stools will be pale grey color in post-hepatic jaundice. Then splenomegaly will be absent in obstructive, whereas variably present or present in this thing. Then pallor will be present only in pre-hepatic. Jaundice mild, moderate, and severe. Splenomegaly I told. Then coming to unconjugated bilirubin will be increased. Both conjugated and conjugated bilirubin will be increased in obstructive jaundice. The serum enzymes will be LDH. LDH will be present in all the cells, the cytoplasm of all the cells. So destruction of RBC leads to increase in LDH. Destruction of hepatocytes causes rise in AST or ALT. AST is also known as SGOT and SGPT. And ALP will be increased in obstructive jaundice. And then we'll come to cyanosis. Cyanosis is nothing but bluish discoloration of skin and mucosa resulting from the increased quantity of hemoglobin, maybe deoxygenated hemoglobin, or maybe abnormal hemoglobin like methemoglobin and sulfahemoglobin. Then if the criteria where deoxygenated hemoglobin will be more than 5% or oxygenated will be less than 80%, saturated 85%, we see cyanosis. Cyanosis, again there are different types: true cyanosis, pseudo cyanosis. In true cyanosis, again three types are there: central cyanosis, peripheral cyanosis, and mixed cyanosis. Central cyanosis, we look for central tongue region. Peripheral cyanosis, the fingertips and all you see. Central cyanosis in heart problems like One, you can remember teratology of palate. You can remember central sinuses. And for serious conditions are teratology, pulmo, asthma, COPD, core pulmonary. Core pulmonary is heart failure because of lung disease. And peripheral sinuses, low cardiac output. These are the causes: low cardiac output, vasoconstriction, because blood is not pumping to the peripheral side, vasoconstriction, atrial obstruction, venous obstruction, or oil viscosity in case of multiple myeloma, where you say Bernstein's protein and polycythemia. Then pseudo cyanosis, maybe because of metals like gold, silver, mercury, arsenic, drug poisoning, drugs, chloroquine, which used to give in malaria, and chlorpromazine, amidorin. These are the drugs which causes pseudocyanosis. Typical presentation not what I guess is cyanosis. Central cyanosis, where you see in case of hypoxia, tongue and oral mucosity. This for examination of peripheral cyanosis: tip of nose, earlobes, outer lips, fingertips, nail bed, extremities. You see, there is a sluggish circulation. Inadequate oxygen supply will be there, and clubbing and remaining things I'll continue in the next video. If you find this video helpful, please do like, share and subscribe to my channel, and if you have any suggestions, let me know in the comment section. Thank you.